let's start this track over because this is the best bomb song. And thank you for tuning in. Appreciate you. KXVS, the voice of Stockton with Donovan and Mr. Details, Dustin Breakwell. This is Governor Don signing off.
This is Barbara Berrigan Perea with Delta Flows, a radio show by the voice of Stockton and Restore the Delta. This is the weekly radio show where we discuss everything Delta related: the environment, water management, water quality, farming, history and culture, public events, recreation, Delta food, and the arts. Tune into Delta Flows on KXVS, the voice of Stockton, streaming live on Facebook and YouTube at KXVS Radio.
KXVS LP Stockton.
This program does not reflect the views of KXVS management or KXVS, the voice of Stockton.
KXVS, the voice of Stockton. It's time for Connections, Peace and Justice Radio with your host, Bruce Giudici.
Oh, good evening. Tonight we are going to be discussing single-payer healthcare and the alternatives, and SB 562, which is the California version of single-payer. And with us tonight we have Max Heinemann and Kathy Mathis, two folks who have been working on getting this bill some notice and getting it passed in the Senate, in the state Senate. And so we can just get started by discussing, well, what I'd like to discuss right at the beginning is my experience with open enrollment. And a lot of people have had to deal with open enrollment this last month, in the month of December. And that's the process by which you have to decide which health insurance plan you're going to be working under in the following year, in 2018. And so not everybody has open enrollment in December, but most everybody does. And so this is where we get to find out how much money the for-profit health insurance companies are going to be charging us for their services. And so I just want to reveal my experience, and I think I've discussed this on previous shows, but I live up in Calaveras County, and Calaveras County is one of the more expensive regions because we are not very well served with hospitals nor doctors. And so we're in what's called Region 1, and that is what we have in California. There's about 10 regions that are judged. That it is how rates are decided by the different health insurance companies, Cigna, Anthem, Blue Cross, Blue Shield, and those. And so what we got to choose this time around was, we pretty much had only Anthem to choose from because nobody really wants to bid in our area. We did have we had an Aetna plan, and we had a possible Blue Shield plan. But Anthem Blue Cross is what we ended up choosing, even though they raised our rates by 9% over last year. And the year before, it was a 34% increase, which was quite a hit. So to cover my family of myself and my wife and my two children, it would cost us about $2,500 a month or $30,000 a year if we were to pay for this health insurance ourselves. We're fortunate that we work for an employer who absorbs a large part of that cost, but what that essentially does is it sort of masks the total cost of the insurance and the services, and what it makes people think is that health insurance really isn't that expensive. But when it's absorbed that much by employers, it puts a strain on those employers, and it makes them feel like somehow they're doing the employee a favor by offering this insurance. And the insurance isn't all that fantastic. For my $2,500 a month, I would have a $7,500 deductible. And would have to pay co-pays and have to pay for like $40 office visits, and those co-pays would add up. So in any case, what we're talking about today is an alternative to that system. And Max and Kathy both know a bit about this subject, and so that's why we wanted to have them discuss what it is, what is SB 562, and what can it do for us.
SB 562 is a single-payer program, which means it works something like Medicare that we're all familiar with, especially us older people. Right. That almost all of our medical expenses are billed to Medicare. Now there are copays and deductibles with the U.S. Medicare program. What we're talking about for the state of California, which SB 562, of course, is a Senate bill, and it passed the Senate this past year, and it was sent to the Assembly, but it was shelved, and it is not going to be available for discussion until next month.
It was pretty famously shelved. That was quite a
Yes.
large uproar amongst the single-payer folks.
And we would like to argue with Mr. Rendon about some of his statements for the reason for shelving, but hopefully we don't have to get into that mud pie, and they will begin to discuss what the Assembly would accept and so on for a single-payer program. Single-payer would be like similar to Medicare, very similar to the medical program they have in Canada, or probably one of the best single-payer programs is Taiwan, which is the most recent country to go to single-payer. In Taiwan, you have a card, kind of like your Social Security card or whatever. Anytime you go to the doctor, to the pharmacy, they run your card, and they have it set up so the next day they know the total amount that was spent for health care so far that year. That's pretty remarkable. Seems like we can't get that information until a year later. Yeah, but anyway, that's one thing that can be done with it. But single payer covers all of your medical costs, your office visits, hospitalizations, inpatient, outpatient, medications, and the SB 562 was written to cover dental, eye care,
physical therapy.
Yeah, mental health, drug treatment programs. Very comprehensive.
Yeah, a lot of things that are not currently covered under a lot of plans.
But hey, Max, how can you do that? How can you pay for all of this without bankrupting our system?
Well, actually, it saves money. That it costs less. Mr. Rendon would like to say that it would cost $400 billion for the state of California per year. Okay. Which is inaccurate. Anytime if you have a conversation with someone about SB 562 and single payer, you'll hear that word, $400 billion. The actual cost that has been studied, and it's going to is going to be a cost of $331 billion. So there's a little bit of difference right there.
Well, that's a significant difference. $80 billion is a lot of money.
Yeah, and the other thing is that we currently, the government currently spends $225 billion for healthcare.
The government does.
The government, federal and state government in California, spend $225 billion currently, on top of what the residents pay. So that leaves a difference of $106 billion.
So that $106 billion is pretty much covered by my $30,000 a year that I have to pay, or my employer has to pay.
Well, probably that more than covers it.
Yeah, right. And then we're also talking about copays and deductibles.
Yeah, no. Not with single payer.
Right, not with single payer.
Yeah.
But I mean, if we're talking about the government paying $220 billion, about $225 billion
currently,
and the total
that's cost, that's a pretty definite figure.
Wow. And so all the single payer has to do is come up with another $106 billion.
And the creators of the bill have it studied. Actually, the University of Massachusetts at Amherst kind of specializes in studying healthcare costs. They're the ones that studied Romney's plan, which was a basis for the Affordable Care Act.
Right.
And they're currently working, I think, on Bernie Sanders and making recommendations. And so they're the ones that did the study and came up with a total cost for the state of California is $331 billion total cost.
Right.
Actually, if you're into looking on the internet, you can see their study. It's available. You can go to coveredcalifornia.org, and then you want to go to the they have several screens that you can go to. One being the bill itself. You can read the entire bill. You can read the entire study done by University of Massachusetts Amherst in their Political Economy Research Institute.
Yeah.
PERI, P-E-R-I.
Yeah.
And you can go to that. You can read a 4-page abstract of the study or an 80-some page description of the complete study. So this is a well-studied issue.
So how does Rendon come up with a $400 billion amount? I mean, it seems kind of out of the blue, and maybe it's just rounding $330 billion up.
That might be what we currently pay when you talk about what amount goes to the private insurers. It could be that difference of $70 billion.
But the difference would be that everybody would be covered.
Well, and the insurance companies won't be making a profit.
Right.
Yeah.
Neither would the hospitals, for that matter, or
Right.
the drug companies.
Yeah, actually, one point that you bring up, this is universal health care for California. It includes all residents.
Right.
So you have to be a resident.
Right. Yeah. So one of the concerns that that some folks would have, and what I would have maybe, would be for a single payer for a single state to take this on. How would that? I guess it could spur the discussion and get the nation moving towards a single payer system, but it could be where California would attract a lot of people who have chronic health problems, and they would be guaranteed health care here, right? I mean, if
You're talking about residents from other counties.
from other states. From other states.
Well, probably there might be some of those, but keep in mind they would have to establish residency in California, and consequently they would be paying taxes in California.
That's right. Yeah. So
They
they
would
would
be-
pay as they go.
Yeah.
Right.
And as a matter of fact, if you look at how it's funded, it's funded by the recommendation from the University of Massachusetts, or one of the recommendations for funding. Was Kathy, you want to tell us about that?
It would be a 2.3% sales tax and a 2.3% gross revenue or gross receipts tax. So you could maybe explain a gross receipts tax, Bruce.
Well,
I mean,
actually,
I think it's basically any good or service that changes hands.
it's like a value-added type of tax, where every time that the transaction happens, then whatever the value is of that. Oh, it's not a value-added tax.
Sorry. It is a tax on businesses that their gross income has a 2.3% tax.
Okay.
And the same as the sales tax. So if somebody comes from another state, they are going to be paying sales tax here.
Right.
Matter of fact, hopefully we'll have some tourists who will pay sales tax, and that will go to our health care. But the gross receipts tax is a tax on the income coming into a business. But it doesn't hit the small businesses because there's a $2 million exemption. The first $2 million that a company receives is exempt. Businesses with fewer than 9 employees is exempt. And businesses with 19 employees, only 1/3 of their gross income is taxed. So now, if this sounds like a lot, that's a lot of money. And as a matter of fact, in talking with the the economist from University of Massachusetts Amherst, they have estimated that the income from the gross receipts tax is going to be well over what they initially anticipated. Business has been really good, so if it keeps up, this amount would be more than sufficient.
Well, another part would be, I mean, another aspect. I mean, this would be one way to fund it, and I can see that would be, you know, adequate. But right now, where I'm working, for the amount of money that our agency, or I work for an agency that has about a $10 million budget, and we pay about $600,000 of towards the benefits of our employees. So that's like 6%. So the thing, and we have to go through an open enrollment process where we decide whether, how we can ration health care to people by saying, well, if you have a certain income, maybe you can get on Healthy Families, or maybe if you're, we try to finagle and try to figure out how to cover people. And so and then when somebody gets married, or somebody has a kid, or somebody gets divorced, you end up having these changes in their healthcare system, in their healthcare, which is what an employer really doesn't. As an employer, I really don't want to deal with that stuff. I mean, that's healthcare. That's not our business. Yeah. And so I'd rather just pay the 6% flat off the top and let somebody else deal with the single payer. And if I knew that everybody in the state were covered, I feel a whole lot more comfortable knowing that somebody who I might hire has gone to a doctor within the last year and might be healthy enough to do the work for me.
And they can go to the doctor in the next week if they become ill.
Right. Yeah, rather than having to worry and plan and figure out, well, have I reached my deductible yet? Right. Or do I have to cut pills because I haven't, because I can't afford the full prescription? I mean, right now, the way single payer is pitched, they call it rationing. But to me, the existing system is a rationing process.
There would be no rationing with this single payer system.
Well, I think you have to understand there's always some level of rationing. It's a matter of who's deciding what gets rationed and how much. Do you want the government to do it under some level of principles, like we're going to cover in general, all of reproductive health, or we're going to make sure dental is covered, or eyeglasses, or things like that?
Well, I think all of those things would be covered. What wouldn't be covered would be abortions, because that's illegal in the United States to use tax dollars for abortion. So that wouldn't be covered.
Under the current system, employers do ration for their employees, and part of it is because they have a small, what you'd call a risk pool. If there are 20 employees at the company, that's the risk pool. You've got 20 employees. If they all happen to be young women of reproductive age, the premiums just shot up because because statistically they tend to need certain healthcare services. Whereas if you have a big pool of the whole state, they actually do know what it costs to insure the number of people in a whole state.
Right. And that was the problem. That was the reason why our rates went up 34% in the prior year, is because we had 3 people who had severe medical issues, and the following year, the insurance companies, I guess, decided to recoup all that money that had been spent on them all in 1 year. And so it was like our rates just skyrocketed because we had this bad experience modification. And that's typical for, like, say, a workers' comp type of insurance, where you have a few have an accident or two that are really costly, and then after 3 years they look back after 3 years and say, okay, you're no longer a real high risk and your rate goes down. I asked the health insurance company, well, is this experience mod going to go away? Or say, oh no, your rates are going to stay this high. Yeah, they don't go down.
Actually, it's kind of interesting because single payer would have a spin-off that would save money in any number of situations, such as workman's comp. Because if all health care is covered, the big cost of workers' comp is the health care that they provide or pay for, pay for the back injuries, so on. If you're a roofer, your workers' comp goes way up, but those would be covered under SB 562. Yeah, so SB 562 is still alive as a possible bill that can be passed in 2018, right? It's been I don't know what the term is exactly, but it's been held up by Anthony Rendon of the Assembly. Because it passed the Senate? It did pass the Senate, yes. And then it was sent to the Assembly. They were going to vote on it, but he held up the vote because that's his position in the Assembly. And he said that he used the terms woefully inadequate to describe it because there was no funding mechanism designated. And California has some specific rules about how much money has to go to the schools, for example, and how much taxes can be raised in a short period of time, things like that. And those would have to be worked around. They have been worked around for other things, but for example, the transportation system and the freeways in the past. But Rendon is very fond of citing these as enormous roadblocks, and since it wasn't all spelled out in the Senate bill, then it just has to sit until somebody, notably the California Nurses Association, who he assumes wrote the bill for the Senate, comes up with the solutions to these problems, not legislators like himself. Right. Actually, the nurses paid for it. They had Amherst write the bill. Well, no, Amherst wrote the study, but the bill was written by senators. I mean, it's a Senate bill. It's written by legislators. Well, I do think it's pretty telling if nurses are so much behind this. I mean, normally you would think that that a group who is financially benefiting from the system that is costing so much, you would think that there would be resistance from folks who are benefiting from the system. But nurses who care for their patients and who see that people are not being served are actually behind this and want to see and have been some of the most vocal people backing this thing. Right. Well, there are a number of vocal people. The nurses have been behind it financially. Yeah, and they're a big, powerful organization, and they've absolutely been spearheading this movement here in California and nationally as well. Yeah, but the thing is, there are maybe bigger and more powerful organizations who don't mind keeping the system the way it is. Right. I mean, you have the hospital associations, you have medical devices, pharmaceutical, but mainly it's the for-profit insurance carriers and the pharmaceutical, because the thing with pharmaceuticals is they ought to be in favor of it, because now people will be able to afford their prescriptions. But if the entire state of California is going to be paying for all pharmaceutical supplies, it gives them a tremendous bargaining edge. That's right. Yeah. And we pay twice as much for our prescriptions in the United States as they do in Canada and Europe. That's right. Well, and that sort of leads towards what we're talking about, what is being talked about nationally. I mean, one of the reforms that Bernie Sanders is coming up with is talking about, I think one of the first things is to allow us to buy pharmaceuticals from Canada. And also to provide some competition, but then also in terms of just the national a national single payer system. Can you talk about that a little bit? Well, I guess I could talk about it. There's been a proposal for years, at least over 10 years. HR 676. House of Representatives 676. That has been a bill that's been reintroduced semi-annually. Since 2004. Oh, okay. By John Conyers. Okay. And we do anticipate that someone else will take the bill up. Because there's been co-sponsors, right? I mean, there's. Yeah, there are currently 114 of them. It's a record. So one of those guys will pick it up. One of them should, we assume. Yes. Yeah, and it's pretty much a straightforward single payer. And actually, if you're interested, the University of Massachusetts Amherst did a study of that bill. It's old. I mean, it's about 10 years old now. But the first paragraph that you read in the study is how many I think it would say save $5 billion the first year that it was enacted.
Wow.
That's 10 years ago.
Yeah.
But, I mean, that's an old study.
Yeah, because the thing is, right now we do have the Affordable Care Act, which has changed some of the dynamics of the financial of how much it costs. So 10 years ago was a different world than now, but I don't know if arguably costs have gone down. You know, I think if anything, costs have gone up because now there's just so much more leverage that the healthcare companies have.
Yeah, HR 676. 676. Is it 676?
676.
676.
And that's the national.
That would be for the entire country. And it's hard to imagine some states getting on board with that. And even though it's quite popular with representatives from California, it just doesn't have the momentum that the SB 562 does in California.
Well, SB 562 has already passed one house of the legislature.
Yes.
Yeah. And now if it can, so right now I heard today on the radio that there was a hearing about sort of a fact finding of what other states have done with single payer, and they talk specifically to the governor of Vermont, who tried a single payer system, and Vermont's has a tiny population, and so the verdict that he came up with was that his market was too small, that it was too difficult for them to do a single payer on their own, and so that was the takeaway that I had heard from that, but it sounds like there is some fact finding that that state legislatures are doing to try to maybe get this thing going up again in 2018.
Now you're talking about in California?
In California.
Oh yeah. The bill is still active.
Still active.
But it hasn't passed the Assembly.
So it could be taken up in the Assembly committee in January.
In January, after January. Well, they'll have, I don't know, they have a period at which they can take it up. I suppose, I don't know, do you know the date?
No.
I don't know. They have 2 or 3 months at the beginning of the year, but by June, usually, that's the end of when you can vote on a new bill.
And Stockton's Assembly person is?
Susan Eggman.
And as a matter of fact, we can give you a telephone number to call if you want to express your desire to Assemblywoman Eggman, or any, if you're in another district, you can call this number. They'll ask you for your zip code and your name, and they will put you through to your assembly person. So,
okay.
Are we ready for that?
Yeah, what's your number?
855-271-8515.
Very good.
And I checked it out tonight. It is working.
So this takes you to an assembly, the assembly switchboard, where you can lodge your.
Actually, I think it takes you to a switchboard operated by the nurses, who then determine who your assembly person is, and then it transfers you to that person's switchboard.
Okay. Yeah, because the nurses are pretty articulate on this issue. They make some very good arguments, and it's going to take some very good arguments because there is just such a large financial resistance to a single payer system. You know, the United States is the only industrialized country that does not, or that does not have this sort of system.
Well, we need, in the interest of full disclosure, the Western European countries all have universal health care. And they have some merged portion of single payer with their previously existing insurance companies. So the more pure single payer ones are Canada, Taiwan, and France, and then Italy, The others all have some vestiges of their insurance program left, which works fine for them. And I was listening to a program the other day. The reason that you can, the countries there can use an insurance company. So actually, in Germany, you sign up for an insurance company, and in Switzerland, you sign up with an insurance company. But they are just they don't make money.
Those are nonprofit insurance companies.
Nonprofit,
Yeah,
yeah.
you may choose from two different plans, but neither plan can make an excessive profit.
Yeah, it's a matter of fact
They're highly regulated.
Right, and the government is able to change quickly. So if there's a change, a crisis, change in issues, the relationship of the insurance companies to the government's in control, and they can make changes very rapidly. I can hardly imagine that in the United States. I mean, so
Really?
that would be even harder to do than this. So
Now, Max kind of skipped over the United Kingdom, which has not just a single payer, but they have a more socialized form of medicine. They have the National Health Service.
Right.
All the hospitals, all of the medical clinics in general are owned and operated by the government. Under a Medicare for All single payer system like we're proposing for either California or the country at large, we'd really maintain, in our vision, a similar delivery system for medical care like you have sometimes in clinics, sometimes in private offices, sometimes in large groups like Kaiser or Sutter. And people could choose where they wanted to go. They would have a card that would be good at any of those places. There's actually a provision in SB 562 for Kaiser, kind of carving it out because they have their own self-contained unit in a lot of ways. But in a large system like that, you'd also have computers that actually talk to each other, which we don't have right now in our fragmented system. So I guess that just clarifies the term socialized medicine versus single payer. That what we're proposing is this similar private provision of medical care, but with one government payer.
in England, the doctors are employees of the government.
Right.
Yeah, they get a salary.
Yeah, and actually, the HMOs, Kaiser and Sutter, so on, are specifically written into the bill. You can sign up with them, and if you seem to like it, you can continue. You have 3 months, I think it was. 3 months. If you don't like it, you can opt out. But then you have to finish out the year.
Okay.
If you don't opt out, you're tied to them for a year.
Okay.
Yeah, but the main thing to think about with improved Medicare for All, which would be the Conyers bill, the national bill, or even California's bill, is it would be comprehensive coverage. It would be what they call first dollar coverage. From the second you walk in with your card, and your card should be good anywhere, more or less, with maybe some of those little provisions set aside. You could have your entire office visit, all the studies, the blood work, the imaging studies, any consultations, any therapy that you needed, any durable medical equipment that you might need, all prescriptions, that would just be already covered. And so people would go to the doctor if they had any concerns. They would get their annuals. They would, get their screenings for cancer. Their children would have their cavities filled. Things that give you a lifetime of benefit. High blood pressure being maintained from the time you're in your 20s and 30s and 40s, so that you're not walking into an emergency room at 65 with your blood pressure out of control for you have no idea how long, and in the middle of a stroke or a heart attack.
Yeah. And blood pressure is a good indicator, because a lot of people are stressed out by not having health insurance. It is a major determinant of quality of life. Whether or not people make major life choices because the employer that they choose may have a benefit plan or doesn't have a benefit plan, or they may stay with a job because that they really dislike because they can't do without the benefits because their benefits are tied with their employer, and so it really skews how well, in general, you could say how well our economy works, because people are making choices that aren't based upon whether or not they're truly gifted at something, but they're making choices based upon whether or not they can get their teeth filled. You know?
Yeah.
Occasionally, I haven't heard it just recently, but I was hearing it a lot. My hair catches on fire every time I hear it. That the United States has the best health care in the world. That
who says those things?
I don't know.
Probably the
politicians.
We do for certain people.
Yeah. Well, yeah.
No,
I mean,
for certain people.
Politicians are the ones who have healthcare, who have a single payer system. They
don't understand what $25,000 or $30,000 a year for health care is. That doesn't, But for someone whose income is $50,000 a year, they're not going to do it.
Yeah.
And anyway, in terms of comparing healthcare outcomes in the United States with the rest of the world, we used to have a longevity that was pretty much on top. We are now I like 15th or something. Most countries with universal healthcare coverage, the life expectancy is 3 to 5 years greater than the United States.
Yeah, I heard a statistic that said that death in childbirth is like I don't know, like we're 20th in the world in terms of
infant. I happen to have that right here.
Do you?
Infant mortality in the United States is 5.8 per 1,000 live births, comparable to the study did comparable countries where in several countries it was 3.4 per thousand.
That's more than 2 kids per thousand more. That's pretty
well. And
striking.
the big one was the maternal mortality. In the United States, it was 26.4 per 100,000.
Mm-hmm.
In Finland, it was 3.8 per 100,000.
My gosh. So we're like 9 times more.
Right.
Yeah.
I mean,
8 times more.
It's huge.
We'll have to ask Kathy to justify that.
Well, I mean, I can't explain all of it. Finland has a fairly homogeneous population. We have a very heterogeneous population. Yeah. So some of it is genetic, but an awful lot of it is the disparity in income. Yeah, and diet and stress and.
Yeah. Right.
And it kind of, if we want to look at the little older population, the Commonwealth Fund found that in the U.S., 19% of individuals had skipped needed medical care, either medication or office visits or even hospitalizations. 19% of our population has skipped some of those.
Wow.
Comparable in other countries, in a group of other countries, at 6%, 3 times.
And the assumption would be that the reason they skip it is because of cost.
Oh yes, because of cost.
Yeah.
Didn't I mention that?
Yeah. Yes. So it's skewing lives. People are lives are lost. And every time I go through open enrollment and we have to make choices and we have to tell people, that their rates are going up by 10%, that people are going to make choices and saying, well, I can't afford that 10%. I'd rather buy groceries or pay the rent. And so they'll drop their coverage. And at that point, they're vulnerable to a catastrophe, and even if a catastrophe doesn't happen, they're vulnerable to not going to regular checkups, to seeing if their blood pressure is high, or if they have any blood sugar issues, or any sorts of things that could be picked up by a regular checkup that they're not going to make because they can't afford it. So this is Peace and Justice Network Connections, and we're discussing single-payer healthcare, SB 562 and beyond, with Max Heinemann and Kathy Mathis. So, I'm struck by, I don't know if you've ever talked with folks who went overseas or went to Europe and had to deal with their medical system. And every time I talk to people, it said, it's amazing. It's a revelation. I just had to go there and they just served me and it didn't cost me anything. And it's like, well, that's quite, and then I've talked to people who come from other countries to come to deal with our health insurance, and it's like a nightmare.
Yeah.
It's like co-pays, or am I covered, and how, and what lab can I go to and what lab can't I go to, and is this MRI covered? And it's like there's just this gauntlet of it. What it seems is the objective is to deny you from getting health care. The whole system is designed that way.
There's a level of lack of stress that I cannot imagine growing up in a country where it's just there, and you don't have to worry about it. If you need it, you access your health care, and if you don't need it, you're fine, and you're not stressed about paying premiums or worrying about what if you get sick, because it's just there. And you and I, having grown up in this country, we really have never known that kind of level of security, and it's a shame. There's no reason for it.
It's sort of like in a country where you don't have access to running water, or you don't have access to an adequate sewage system,
right?
Where we have clean water.
Those things.
We have those things
for now.
Knock on wood. But still, but it's the same sort of comfort that you would have for those sorts of things. And it's really not, even though Anthony Rendon would say it's a matter of cost, it's really not a matter of total cost.
Oh, it's a matter of this saves money.
And it's a matter of priority.
Yeah.
It's a matter. I think that's the thing that I find so disingenuous about the roadblocks that he throws up. We listened to. Before we came over here, we listened to a piece he did on KQED last week, and he was taking calls, and he kept repeating his same two or three, woefully inadequate, GAN limit, Constitution, I forget. There were a couple of them like that. So, we were looking up the GAN limit and finding, John Garamendi found a way to get around that in 1999 when he wanted to help improve the roads. And, this could be done. The legislature knows it. They're counting on our ignorance. They're counting on our inertia. They're going to be surprised. There's a lot more activism behind this particular bill than they think. And Rendon may find himself in some trouble if he doesn't make a 180 and get behind this bill. He talks about a progressive background. He talks about having worked in nonprofits for years. He's kind of saying, well, gee, I've been a single payer supporter for years. It's just this bill.
This version.
This bill. There's so many questions I have, and I had to pocket it because it didn't answer all of those questions first. So I think that's a good thing that he didn't back himself into a corner, because he's going to find that there are a lot of people within his district and within the state of California who are going to push to make this happen. And it's just going to become politically unviable for him not to back it.
If it's important enough, people find ways to get things done. And it just has to, people like you and me and Max have to, and many people who are listening to the show just have to let our assembly people and our governor, because ultimately if it does pass the assembly, it's going to have to get past the governor. And the governor is going to have the exact same, and the governor tries to place himself as being a fiscally conservative person. And
he's a little unpredictable at times. He's unpredictable,
and the thing is I haven't seen him leading the way in single payer.
No,
so the thing is that if it does get past the assembly, which it very well could, it could face a veto.
Well, yes, but even if it passes the assembly and the governor, we are still probably faced. The real thing we have to worry about are the insurance company. They have billions and billions of dollars to fight it. They will start a court case that will require a plebiscite, a vote of the state in the state.
Right.
So we know that's coming.
Right.
And I don't know if that's what Rendon's problem is. He doesn't want to be against the insurance companies in a fight that.
I think the odds are good. That's a big part of his problem. If that isn't his entire problem.
Right. I mean, yeah, because he thinks he has a future in terms of
they are such a powerful force.
Right, and that's why this SB 562 is part of it is to get a bill passed, but it's also to educate people that there are alternatives to the horrible system that we have. There is an alternative to the horrible system that we have, that it won't cost more than what we're already paying. And what it means is redistributing what money we're paying now from folks who are reaping enormous profits to a more towards a nonprofit system, and taking those profits and using those to cover everybody.
Yeah. Amherst anticipates that it would save 18%. Total savings. That would be savings from the private individuals, savings from employers, savings that go to our GDP, and
it's important because California is 1/10 of the nation. California is a leader. And when if California makes this decision and leads the way, I mean, California is leading the way on climate change, and on actually, we actually decided to increase taxes on ourselves, so that we could actually pay our bills,
fund our public schools,
right?
Yes.
Yeah. So I mean, the
fix our roads.
Yeah. So there's a certain pragmatic population here, and so. For this to move forward and for us to educate folks that this is possible, that it's not impossible, that it's something that we can achieve, it will tell the nation that this is a movement that can take over the nation.
Well, we need to shift our thoughts about healthcare. I think a lot of us have done it in our private lives, from thinking of it as a commodity, like a piece of candy that you buy at the store. Or even a service. We're not paying for our house to be cleaned here.
Right.
These are necessary goods and services that we need. Thinking about it in terms of like public schools or the fire department or the police department or an ambulance, although I gather people have to pay for those. I'm a bit taken aback by that. But if you think of the medical infrastructure as something you access as you need it, and you pay your taxes so that it will be there when you need it, and it'll be there for your neighbor when he or she needs it. That's how we need to start thinking about it. We need to stop thinking about it as a for-profit venture that a few people can profit off of.
The way we're looking at it now is like, your house is on fire, and the fireman comes up to your house and says, "Well, have you paid your taxes?" Say no. Well, then let it burn. And then that's essentially it. When you're sick and you go to the hospital, and they say, "Do you have insurance?" And they say, "No. Well, I'm sorry, I can't serve you. You're gonna have to go to a different hospital."
I mean, there is an interesting parallel to that, though, because if you think of about how many people who've owned homes for 20, 30, 40, 50 years, and they've never once had to call the fire department. And yet, they not only pay taxes that support the fire department, they pay for fire insurance to their, their private insurance company. And, they don't say, well, I'm only paying my premium the year my house has a fire.
Right.
And yet when you talk about, the Affordable Care Act as inadequate as it is, the individual mandate is there to fund for the entire risk pool. And I have to say, just to back up on some of this, when we talk about healthcare, we use a lot of jargon, and I think maybe to some extent it might be helpful if we go over a little glossary before the end of the visit. But if that would bore everyone, we could do that another time. But like, we started out using the term deductible and copays, and those may seem like simple words to you and me because we've been dealing with these systems for a while, but I remember for a long time not quite understanding, say back in the 90s when Hillary Care was introduced. They seemed to use words like deductible and copay, and I really didn't get it. So maybe just to back up, a premium is what you pay to have a health insurance policy. For people who are employed, their employer may pay the whole premium or may pay part of it.
For me, that was the $2,500 a month, which we end up paying a quarter of, and our employer pays 3/4 of.
Okay, so and then the deductible is the amount you pay before you pay as the patient. Before any of the benefits kick in.
Right.
And that may vary as to how it's administered. It can be you don't get anything until you've met the deductible, or your copay for office visits and everything is like $20 or whatever, $40, whatever it is, but they cover the visit up until you get to a certain dollar amount, and then they cover it completely.
Right.
So
a deductible is a minimum amount that you have to pay every year, and it resets every January.
Well, like the first $4,000, I'm on
you have
the
to
hook
pay
for
all
that.
of it.
But if I get hit by a car and it costs $100,000, I pay the first $4,000, and the insurance company pays the $96,000.
And then there's something called an out-of-pocket max, which is actually helpful.
Right.
Like beyond $7,000 in a year, you may not have to pay. That's a good insurance policy.
Right.
Copays are the amount you have to pay. It's usually a percentage, so you may have a $10 copay. This is not a percentage. You may have a $10 or $20 copay for your office visit if it's an annual, or if not, if it's not an annual. If it's a problem visit, you may have to pay 25% or 50%. Just depends on the terms of your policy. And copays apply to pharmaceuticals as well. So when you go to get your medication that your doctor prescribed and you show up at CVS, they may tell you what their price is, which may vary. You may get a better price at Rite Aid down the street, but your insurance company may agree to pay a certain percentage whether you buy it at CVS or Rite Aid.
Or your insurance company might say, your insurance doesn't cover this drug. Can you call your doctor back and see if you can get a cheaper drug to substitute for that?
Yeah, that's called a formulary. Doctors get lists from insurance companies lists of drugs that are covered and drugs that are not covered.
That's impossible at a doctor's office for them to know what different insurance companies are going to, because there are at least 25 insurance companies. They all have different formulas.
Well, that's the thing. In this multi-payer system, we haven't even gotten into this. The private practitioner, the individual practitioner, who generally has a fair amount of autonomy in deciding therapies, medications they want to use and the like, they have a different set of rule with each insurance company, and that goes to covered procedures. For example, if somebody needs an operation and they want to have it at a certain hospital, different providers different insurers may or may not have a contract with the hospital and may agree to pay a certain amount at this hospital and a different amount at a different hospital, and it's really hard to keep all that stuff straight. And there are huge billing departments in every medical practice. I work for a medical practice that has 15 to 20 doctors, and we have at least as many people in the billing department to keep that sorted out. For our surgery schedulers who need to schedule patients to get operations, they probably spend half their day waiting on hold for insurers to get what they call prior authorizations. That's another word for our glossary. That's approval from your insurance company that the service that you want to get as a patient will be paid for.
Yeah, and I remember I worked for a group of medical clinics for a year and a half on a nonprofit basis, and we had a billing department, and the stress was always between the doctors who wanted to probably keep the cost as low as possible for the clients because they were low-income clients, and the billing department, which was always trying to encourage up-billing because you say, well, is this an enhanced office visit? So, are you going to be able to charge an additional $30 for this? Or when they move from the 5-digit billing code to the 9-digit billing code, now billing departments are able to bill a lot more extensively and a lot more detailed way that is, I'm sure, is not going to be used to save money. I mean, right now it's being billed as being a way to more accurately describe what services are being provided, but in reality, what practically is going to happen is more money is going to be charged to the insurance companies and hence to us through increased premiums through this process. And this would be different under a single payer system.
Well, it might or it might not. A lot of the way they manage this billing issue is under the Affordable Care Act, most providers went to a computerized system. There's a penalty if you didn't, and so a lot of these coding systems require certain things to be in the note and certain things to be checked off and so forth. And it takes about an extra 5 minutes per patient. I say this as a physician who sees patients all day.
And that's a lot of time.
Yeah, it does. Each patient, you're adding a few more clicks to your chart. You're adding a few more codes to the bill. And so then you're done as a physician. You click a couple more boxes, and the note is locked, quote unquote. Then it goes off to the billing department that inspects it, and may or may not suggest you make a few changes or add a few codes or whatever. But once you get that system down, that's fine. But do we need a lot of what's in these notes? In my own opinion, no. And I get it that they're trying to amass a lot of data, and hopefully they'll be able to make, sweeping analytical decisions about our population. And I think there is some concern that if we go to a single payer system and we've got a uniform set of computerized records, and we can use actual analytics to decide what the trends are in healthcare, and that can help guide us in terms of the population as a whole, that certain individuals will be lost. But in the meantime, it's pretty crude. It's a lot of different computer systems, it's a lot of different insurers. I'm not really sure they're making good use of the data. In the meantime, the providers are having to jump through, providers meaning physicians and nurse practitioners and the like, we're having to jump through a lot of hoops and check a lot of boxes that don't seem terribly, useful.
Well, right now also, just because it is a for-profit system, it sort of skews the, you don't really know whether or not these codes are being changed because of for-profit reasons, or if it's because of having better, trying to get better outcomes, or to figure out what's going on.
Yeah. What do you think, Bruce?
I don't know.
In general, it's assumed that the physician's office spends 20% of their income to
just billing.
Billing.
Yeah, is that insane?
Well, I know in our department when we're doing open enrollment, we have at least 1.5 people working on open enrollment and working on adding a baby, subtracting a divorced spouse, and that sort of thing. Just dealing with and then dealing with the different costs, because when you're 60 years old, the rate is different than when you're 20 years old, and when somebody changes in age, the rate changes. But anyway, so this has been a wonderful discussion. I'd like to get together again, maybe in 3 months, maybe in March, when
or maybe whenever this is going to come
whenever
up.
Whenever it comes up in the assembly. Yeah, let's get together then and see where the dust is landing, and we'll see what's going on nationally as well. Thank you, Max. Thank you, Kathy. It's been a wonderful discussion.
Thank you, Bruce.
I want to repeat that number to call your assembly person, 855-271-8515.
To support SB 562. Thank you very much.
Absolutely.